Hi everyone, and welcome to The Journey. Today we're going to talk about peptic ulcer disease. So with peptic ulcer disease, also known as PUD or PUD, right, it's going to be a loss of mucosal layer or an erosion of that mucosal layer, which is also known as the intima, which means the first layer. And it pretty much goes into the submucosal layer. So sub means under the mucosa layer, okay? So that erosion is there and it is completely gone. So just think of, you have, I'm going to put right here, right? Put right here, you have 4 different layers. And the first layer is your mucosa, and you have your submucosa. All right, this whole layer is completely gone, just like that. First layer is gone, and it dips into the next layer. All right, so with that, you have 3 different types of ulcers. Well, 3 main types, okay? You have esophageal ulcer, gastric ulcer, and duodenal ulcer. And pretty much the only difference is where they're located. They're still the same as far as the representation of the erosion of the mucosa layer, all right, because that's what makes it an ulcer, but it's just where it's located. So, of course, the esophageal ulcer is located in the esophagus, gastric is in the stomach, and the duodenal ulcer, that's the only one that I can say is probably tricky. But if you know by now that the first part of the small intestines is the duodenum, then you know that this is located in the small intestine. So here we have the causes of peptic ulcer disease. So we have medications like your NSAIDs, right? And then you also have corticosteroids that can also cause that erosion as well. H. pylori bacteria, which is transmitted either from the fecal route, saliva, food, or water, right? And what happens is it progresses from a superficial chronic gastritis to atrophic gastritis, and atrophic means, you know, the narrowing or the shrinking of, right? And which leads to PUD, right? And it can also eventually lead to a gastric cancer and gastric lymphomas, okay? So H. pylori is a very serious matter that you want to make sure that you treat right away once you find out that the patient does have H. pylori, because it can lead to other things besides just gastritis or peptic ulcer or, you know, any one of these things here, all right? You don't want it to complicate anymore. Also, excessive amount of hydrochloric acid. And then you also have food that increase the hydrochloric acid within the body as well. So with that said, you have milk, you have alcohol, and the abbreviation for alcohol is ETOH. So if you see me put this instead of alcohol, it's the same thing. And they do put this as far as on the medical charts and things like that. So just kind of get familiar with seeing ETOH because it means the same thing, okay? Caffeinated beverages, your soda, which is your carbonated beverages, all right? And smoking, all right? And with smoking, like I said before, smoking deals with a big, a lot of different organs that it damages. And I said one was particularly the vessels. Well, at least when it comes to smoking in this aspect, what it's doing is it's stopping the production of bicarb that the pancreas makes, that's secreted into the small intestines once all of the food has now entered into the duodenum area, right? The pancreas secretes the bicarb and it goes into the small intestines, and it blocks that production from happening, which only increases the acidic levels, okay? So that's how smoking contributes to the peptic ulcer disease, all right? And then you have stress. Stress plays a very important role, and you have 2 different types of ulcers that you can get just because of stressing, all right? So that's why you want to make sure you have your stress management, and I understand being in nursing school, it is very, very stressful, but you always have to take time out and just relax. Do something fun, you know, watch TV, go to the movies, do something, because stress can play a big factor with having a lot of different diseases and a lot of complications and different disorders. So with stress, there's 2 different ulcers. You have the curling ulcers and you have Cushing ulcer. And I know sometimes it can be very hard to kind of remember, so I put hints for you to understand or kind of get a better understanding. So curling ulcers deals with anything that deals with a burn, okay? So when your body is not just only like when you're stressed out, but stress as far as stress on the body, okay? And one of the biggest stress that you can have on the body is when the body has a burn, because a lot of people think that you die from the burn, and it's not the burn, it's the fact of dehydration, okay? So with that said, it puts your body into a shock, and it puts a lot of stress on the body, okay? And when that happens, you get an ulcer called curling ulcer, and it particularly pertains to the burn. All right, so with curling ulcer, I said you can think of a curling iron. Ladies, when you have your curling iron, right, it's hot, you burn yourself from it, think of curling ulcer. All right, so curling ulcer deals with burn. All right, and you want to monitor for 72 hours the patient when they develop the curling ulcer, okay? And then also here, you have Cushing's ulcer, and Cushing ulcer deals with the head, so stress on the head, which it can be increased intracranial pressure, which I have a video. So if you guys want to check that out or know more information about that, you guys can go ahead and go to the playlist and scroll down to the neuro section, and you will see the increased ICP there, and that will give you more information about what kind of stress the body goes through as far as the brain wise, so that way you can know how this ulcer develops. So Cushing ulcer, you can think of pillow, because when you want a cushion, right, you want to cushion your head, right, you sleep on a pillow. So you can think of it like that. So Cushing's deals with the head, and what happens is it ends up producing more gastric acid. So when you have more gastric acid that is being produced, eventually it increases the acidic level and causes that layer to be eroded a lot faster. All right, so these are the two ulcers that deal with stress. And then you have hereditary, which is just family genes. There's nothing you can do to go around it. It is what it is, right? So that's your genetic factor. You also have tumors. Tumors can cause peptic ulcers as well. How? Because of the excessive amount of a hormone called gastrin. And what gastrin does, it stimulates or secretes the gastric acid. So you can have a tumor in the pituitary gland or any part of the brain that deals with the function of secreting those hormones to the stomach area. And with that said, it affects the gastrin, and the gastrin ends up secreting too much of the acidic levels, okay? So that's how your tumors can cause it. And then you also have GERD, right? And with GERD, right, gastric esophageal reflux disease, you have a backflow of acid going into the esophagus area, and that's one of the main reasons why you end up getting the esophageal ulcers, mainly because of the acid that is going into that area, right? It starts eroding that layer a lot faster, okay? So all of these different things here are definitely going to play a part in causing peptic ulcer disease. All right, clinical manifestations. So we have persistent pain, right, which is that gnawing, sharp pain, right, in or to the left of the mid-epigastric region, which occurs 30 to 60 minutes after meals, okay? Next thing you have is your poor appetite, you have bloating, you have nausea and vomiting, and you also have your weight loss. All right, okay. So the complications. The complications are going to be a hemorrhage, you're going to have perforation, pyloric obstruction, or GI bleed. Now with the GI bleed, there's two different types of blood that you want to pay attention to. You have dark red blood, which is also known as tarry stool or melena, and what it is pretty much digested blood, okay? So that tells you where your ulcer is located, okay? So when they tell you the patient had dark red blood, right, that can kind of get you an understanding of where it's going to be located. And that has to be located somewhere between the esophagus to the stomach, right? Because you have the esophagus up here, the stomach is here. When the body then goes and digests that, right, it's going to be a darker red because it's been digested, right? So that lets us know exactly what region the ulcer is occurring or happening in. And then you have bright red blood, which bright red blood is non-digestive blood, so that's hence the word why it looks bright, right? And that is below the stomach to the rectum. So anywhere else between from the small intestines on down to the colon area, right, or to the rectum area, that will definitely let us know that, okay, this is happening on the lower GI tract versus the upper GI tract. So dark red blood and bright red blood gives you an idea of where the ulcer is located. All right, and the reason for the bleed, again, remember that layer has been eroded. Okay, so there is going to be blood in that area. There is going to be damage in that area, and if it is irritated by food, by medication, by stress, it will then go ahead and bleed. Okay, because it's pretty much just like it's like you have a scab, a cut, and pretty much what you're doing is pretty much digging into it even more when you're irritating, right? And when you pick off the scab, sometimes you end up having a bleed. So that's where you get the hemorrhages. That's where you get your GI bleeds from. Okay, and one thing with peptic ulcers, they are going to stay for as long as you live. They are going to stay. So your best thing is to try to prevent. And the reason why they're going to stay is, think of like an actual cut, right? What helps the cut to heal is when you have that scab over it. That scab then eventually fades away and it starts to go back into regular skin. So it gets to heal. With an ulcer, it's always in a wet environment, right? And like when you have a Band-Aid on and you put a Band-Aid on a scar or so, right? The Band-Aid keeps all that moisture in. The wound gets soft, right? And makes it more accessible for you to hit or bang yourself, and eventually it bleeds again, right? So you have to be more sensitive when the wound is a lot more moist rather than when it's dry, right? As soon as you take that Band-Aid off, once that Band-Aid is off and the air gets to hit it, right, and that wound can harden. And when it hardens, the scab is there, and then eventually it gets to heal. So think of that same concept in your stomach, right? An ulcer is pretty much a wound in your stomach, but because the environment is constantly moist, right, it never gets to fully heal. It will stop bleeding for a little bit, but any little thing that you may do can irritate it and cause it to bleed again. All right, so this is why you can see complications within having your peptic ulcer. All right, so now we have Zollinger-Ellison syndrome, also known as ZESS, and ZESS is pretty much a severe type of peptic ulcer, and this is happening because of the extreme gastric hyperacidity that is occurring, that inactivates the pancreatic enzyme, and it secretes more of the gastrin hormone that I was telling you about that constantly increases the gastric acidic levels, right? And it can be because of benign tumors of the pancreas. And also too, there's hyperacidity in the duodenum, depending on where the zest is. So it can be in the small intestine or it can be in the stomach. Of course, if it's in the stomach, it's hyperacidity in the gastric area. If it's in the duodenum, it's hyperacidity in the small intestines, okay? And again, it does the same thing. It inactivates the pancreatic enzyme, okay? So we're still on peptic ulcer. This is just a severe case of a peptic ulcer that is called ZEST. So the clinical manifestations of ZEST, right, are going to be either asymptomatic or symptomatic. And of course, if it's asymptomatic, that means there are no symptoms. They just go, you know, through their regular day-to-day activity, and there is no signs of any distress or anything going on with them, okay? But if they are exhibiting symptoms, right, they are going to have dull gnawing pain, right, burning in the mid-epigastric area or in the back area, all right? The pain is relieved by eating, all right? That is the big key thing, all right? And remember that because they like to ask questions about that, right? Pain is relieved by eating, okay? Or taking alkali, which is pretty much your Tums or your antacids, your neutralizers, right? All right, then you have your pyrosis, which is pretty much a fancy word for heartburn. And you have your constipation or diarrhea. And you have your rectal bleeding, whether it's tarry stool or melena, either or, they both mean the same thing. Or if you have that bright red blood. Diagnostic testing, how do we know if this patient has a peptic ulcer, right? So you're gonna have a radiographic study that you can do, endoscopic studies, test for H. pylori, and when you test for H. pylori, there's two different ways you can do it. You can breathe into a particular type of bag, breath urea test, and you blow into a bag, and this is an outpatient procedure. Then you have a more accurate way, which is a blood test, and what it's doing is going to count the bacteria count that is in the body, and that's going to give you a better way of knowing or determining that this patient has H. pylori, and this is an inpatient procedure, all right? Now, as far as Endoscopic studies, a lot of times the doctor would schedule an EGD, which is an endogastro duodenal scope, which pretty much is going to check the esophagus down into the stomach, down into the first beginning part of the small intestine, which is the duodenum. So, of course, you do need consent for those type of procedures. You want to make sure you get your consent from your patient. If the patient is not able to give consent, whether they have altered mental status or they're incapacitated at the time, then you can get it from a family member or the person who is of healthcare proxy, or someone who they have already have as their healthcare surrogate. And if they don't, then of course they will go to the family member who's in line, right? It is an invasive procedure. They do put the patient under anesthesia, right? And with this study, you want to be on an NPO diet, right? You don't want to have anything going on in your stomach. You want it to be as clear as possible, so when the doctors get ready to put that scope down, they're able to see just the stomach area, see the lining, see the intestines without it being bombarded with food, okay? So the main thing is keeping this person NPO for the procedure, making sure you have the consents. They are going to be put under with anesthesia, and if they need to continue, once they've checked whichever area, whether it's the upper or the lower, depending on the type of blood that they're seeing, whether it's bright red blood or dark red blood, right? They may do a colonoscopy, which is pretty much going to show from the rectum area. So they will definitely tell the patient, they may put them on a medication called Go Lightly, and with that medication, oh my God, it is such a big bottle that they have to finish, and it makes them constantly go to the bathroom because they want to flush out everything, every stool that is in those areas, in those in the large intestines area, because they want it to be completely clear. So again, it doesn't block the vision and the view of the actual lining, so that that way they can see it. And it's pretty cool. If you get a chance to see it in your clinical settings, I say go for it. It's very interesting to see the inside of the body through the camera, especially when it gets to the small intestines. You can see that the little villi is just flushing away, flapping back and forth. It's really cool. So if you get the opportunity, I say go for it. And they'll show you exactly what they use, the technique, the equipment, very, very expensive equipment. So again, this is probably the main way of them figuring it out, okay? And then you can also do a CT scan or something like that. But again, what's really gonna show is that EGD, okay? Or the colonoscopy, depending if they're bleeding from the other way, all right? But they can also do monitors to see different things in the area in the stomach that's eroding or going wrong, okay? But that's your best way, is through the scope. Now we have nurse interventions, and for our nurse interventions, this is for peptic ulcer in general. So this is for zest, this is for peptic ulcer, okay? Because zest is a type of peptic ulcer, just a severe type. But the treatment's all going to be the same, because nevertheless, it is a peptic ulcer. All right, so one thing we want to do, we want to reduce stress, okay? Mental stress, physical stress, we just want to reduce stress, right? Because like I said before, stress causes a lot of things, a lot of dysfunction to occur within the body, right? Smoking cessation, right? We want them to stop smoking if possible, right? So you want to give them the smoking cessation packets, let them know how they can get started. They can do the nicotine patch. There's so many different options out there for them to literally consider that, you want to provide that opportunity to teach them about smoking cessation, okay? Avoid irritating foods, okay? And we talked about that before. You have milk and proteins, which produces acid, so you kind of want to let them know that they're going to have to change their intake on these types of foods, as far as spicy foods, greasy foods, all those type of foods that are going to irritate the peptic ulcer. You want to let them know, hey, you can avoid them or in moderation, okay? Next thing we have is you want to monitor for vital signs and symptoms of bleeding. And one of the two main vital signs that can tell you if a patient is not doing so well is your heart rate and your blood pressure. So BP is your blood pressure, HR is your heart rate. So your heart rate is going to go up as your blood pressure goes down. And the reason why is that because you're losing blood volume. So the blood volume is going to correlate with your blood pressure. So the pressure of your blood is going to be low just because you don't have blood volume. And then your heart rate is going to go up because the body is trying to compensate for the fact that we have a lack of perfusion, that the heart is going to try to pump faster and faster to try to compensate to bring blood supply to those areas. So again, with your vital signs, heart rate is going to go up, BP is going to go down. All right, so that's one of the things that you want to monitor for your patient to see if they are bleeding. Also, too, the obvious, when you take them to the bathroom, look and see, right? Say, don't flush the toilet, I just want to see, especially if you know that they're GI bleed and you know they have the peptic ulcer already, the EGD confirmed that they do, right? Don't flush, let me go ahead and check. Or these patients may be on bed rest or they may be on a bedside commode. Again, you want to look and see and report those things to the doctor, all right? Again, you want to administer small, frequent bland feedings whenever it is safe to do so. I know the doctors like to keep them NPO just because they are actively bleeding. They don't want any irritations going on with the stomach at all. Then they will bump them up to a clear liquid diet, from a clear liquid to a full liquid, then from a full liquid to a bland diet, and from a bland diet, so on and so forth, till they get back to an irregular diet or modifications within their diets, okay? So a bland diet, some things that you may see on a bland diet is bread, plain rice, applesauce, and tea. And with that, it's a diet called the BRAT, all right? The BRAT diet, B-R-A-T, bread, rice, applesauce, and tea, okay? That is your bland diet, all right? So if you ever forget what are certain things that are going to be on a bland diet, you think of a BRAT diet, okay? And with that, you are going to have bread, rice, apple, tea. And I'm just saying, just because you may have questions where they say the patient has this, they just recovered, you know, what kind of foods would the nurse administer to this patient, right? And you may see, you know, bread, orange, which you know orange has acidic levels in there, so you already know orange cannot be it, right? But you may see some of these things here. You may say, I'm not too sure what can they eat, right? So you can kind of think about this as your bland diet, all right? So think of BRAT, right? B-R-A-T. So that kind of gives you an idea of what kind of foods they will be eating, all right? Next thing you want to do is you want to educate your client about preventive measures, right? Because sometimes these things can be prevented, right? You want to teach them about the smoking sensations, the eating of the certain foods, right? So you want to help them to prevent these things from happening. Also, medical management, right? And with your medical management, this is where you have your different types of medications. So you have your proton pump inhibitors, you have H2 blockers, you have antacids, right? And with those, right, you have your proton pump inhibitors. They are your anti-acids, okay? They are different from antacids. Antacids are usually your neutralizers. They are more alkaline, so that way when they go into the GI tract, they are able to kind of balance out the pH. So antacids balance out the pH levels, okay? Sorry. Antacids balance out the pH level. Anti-acids, right, against acids. So it's going to decrease the production of your gastric acid production, okay? So just remember those things, because again, it can be tricky. It's very, very close. Antacid, anti-acids sounds very similar. The wording and spelling is pretty similar, but you need to know antacid, A-N-T, right, is my neutralizer. So this is my neutralizer. Anti-acids are my against acid, okay? So try to think about it against acid, okay? All right, so with this, you have a cocktail of medication that you are going to get, because one, H. pylori is a bacteria that is very resistant, and you want to make sure that you tackle it hard, because you don't want it to eventually causes all these things to come about, okay? So you want to decrease it as much as possible to the point where it's at low levels, where it's not doing any harm, all right? So with the H. pylori, there's a treatment regimen. You're going to use 2 antibiotics, whether they are going to be amoxicillin, clarithromycin, metronidazole, or tetracycline. So the doctor will take their pick and let you know what 2 combination of antibiotics that they're going to use. Then they're going to use 1 proton pump inhibitor. So those are 3 medications that they're going to have: 2 antibiotic, 1 proton pump inhibitor. And they're going to have that regimen for at least 7 to 14 days. And they prolong it because, again, you want to make sure that you lessen the chance of the H. pylori getting resistance. And also, too, you want to make sure that the patient is going to get better and that the healing process is going to occur. And if the H. pylori is what's causing the peptic ulcer, then that is what you want to tackle, okay? Now, you have a second option in case the first option does not work, or you need something that's going to be strong because you want to make sure that this is a once and for all, going to be a done deal fight. So what you want to do, you're going to use 2 antibiotics, right? Antacid, which is going to be your Bismol salt, and then you have your proton pump inhibitor, all right? So this is going to be 4 medications versus 3 medications. So the only addition here is in green, okay, and I color-coded them just so you guys can see the differences between the 2. So as you can see here, I come over here, all right? You have antibiotics in purple, and you have your proton pumps in orange, and then I have your antibiotics again in purple, and I have my orange, and as you can see, the only thing that is different, the only thing that is added is my antacid, which is my Bismol salt, which is pretty much Pepto-Bismol, okay? And you may take it for a longer time period. It may be the same range depending on how long the doctor requests it for, but I know typically they go for a longer time period, and it may go for 14 to 21 days, all right? So again, this is your treatment plan that you're going to have for your patient if they have the H. pylori within their body that's causing the peptic ulcer. This is the regimen that they're going to go by, all right? So I'm going to step back just for a little bit so you guys can kind of soak that in. I know it's a lot, but I will definitely have more information about these types of medication, about the H2 blockers, the proton pump inhibitors, the type of drugs that are in that category, the mechanism of action, the side effects. All right, I'll do that all on another lecture. So stay tuned for that, and I'll put it down in the description box so that you know that's going to be the part 2 of this, which is just pretty much explaining the pharmacologic part of these medications, okay? So you guys can get a better understanding of exactly how these drugs are working and how they are effective, all right? So I'm going to step back so you can see the treatment regimen. All right, so now we have nursing interventions during the active bleeding, okay? So I'm just going to go ahead and highlight here so you can see that this is for active bleeding. So first thing you want to do is monitor your signs and symptoms. Not signs and symptoms, your vital signs, okay? And your main 2 vital signs, like I told you before, is your heart rate and your blood pressure. So your heart rate normally tends to go up as your blood pressure tends to go down, all right? You also want to assess for signs and symptoms of dehydration, hypovolemia, right? Shock, sepsis, and respiratory insufficiency. So you want to make sure that, you know, you're preventing these complications from occurring, okay? So again, you want to be monitoring, making sure if they're going to the bathroom frequently, that you're looking to see how much blood is being put out, the color, the texture, if it's clotted, and you want to call the doctor and let them know. You want to check your vital signs, make sure the patient is stable, make sure they're not exhibiting any symptoms of further complications, okay? Next thing is, they're probably most likely they're going to be NPO, all right? Just about every GI bleed that I've encountered, they are NPO, okay? So they're going to be an NPO status, and you want to administer IV fluid replacement therapy because, again, they're going to be losing fluids, so you want to make sure that you're giving them fluids, okay? And you're monitoring input and output. So eyes and nose, is a thing in the hospital that they use for input and output. So if you hear the doctor say, what was the I's and O's, right? That's exactly what he's talking about, input and output. All right, next thing that you have is you want to monitor your H&H. And your H&H is pretty much your hematocrit and your hemoglobin. Those are going to be your best friend when you have a person who is a bleed. Whether it's a GI bleed, whatever type of bleed, you always want to check your H&H levels, because your H&H level is going to let you know exactly what's going on with the blood. All right, and the type of test that they do is your CBC, which is your complete blood count. At our hospital, we kind of do it every 6 hours or so. If we have a GI bleed type of patient, we do monitoring of CBC every 6 hours. All right, and if the hemoglobin drops below 8, we do give blood. But again, you want to follow your hospital policy, or when you're on the clinical site, look and see exactly what the hospital policy is, because again, every hospital is different. But I know from where I work, hemoglobin less than 8, or if they're actively bleeding. So sometimes they could probably come in with a 13 hemoglobin, rate, a level, and it starts dropping to 10. The next thing you know, it's at 9, right? And they're actively bleeding. Then sometimes the doctor will go ahead and put in orders to give blood, because he knows eventually this patient is still bleeding. The hemoglobin is just going to go down. So rather it go all the way down to below 8 to then give blood, he would then proactively give a unit or 2, depending. Okay. So next thing we have is, when you get to that point where the hemoglobin does drop, you want to administer your blood, right? Your blood transfusion as it's ordered. So sometimes it may say give 2 units, give 1 unit, right? So you want to follow your orders of how they want the blood to be given. So with blood, of course, you need consent from the patient. You need to go over if they ever had a blood transfusion before, and if they ever had a blood transfusion reaction. You want to make sure you go over those signs and symptoms of what reaction that they will have, whether they will have the itchiness, the throat swelling, right, the hives, burning sensation to that site of where the blood is going in. Whatever it may be, you want to definitely explain to the patient and let them know, especially if it's their first time and they're receiving blood and they accept it and have given you consent that it's okay to give blood. You want to make sure that you explain these signs and symptoms, because they may think that, oh, maybe that's how it's supposed to be, but you want to let them know, no, if you feel your throat closing up, you need to press that call light, or you need to yell, or you need to say something, okay? If you feel itchy, again, ring the call light, let us know. And even though the patient may be itchy, that's not always a reason to stopping the blood. What they may do is they will order Benadryl with it, okay? So some people, the blood may get them itchy, or so if they had that experience, then for future references, they will always get blood with the Benadryl, all right? But if it's an itchiness where it's causing the throat to swell and it's more complicated and they have more of an adverse reaction, then of course that blood will be stopped, okay? So with the blood transfusion reaction, I remember I learned it that we checked off with 2 RNs, not LPNs, not any other type of nurse, but an RN, okay? 2 RNs have to sign off on the blood and check to make sure. At our hospital, we don't have that anymore. It's used by a whole scanning system, but again, other hospitals are different, so you want to make sure you're following the hospital policy and their protocol. But for our hospital, it's a scanning system. It's 1 nurse and she scans. Anything that goes out of that scanning system that is wrong, we automatically send back that blood, okay? But other than that, and we check it off with the person in the lab. When we go to the blood bank to pick up the blood, we check it off with them, and then when we go to the room, we check it off by scanning, okay? So again, every hospital is different, so follow your hospital policy. All right, also when you're giving blood, another thing is that you want to document vitals the first 15 minutes before you give the blood. All right, so 15 minutes before you give the blood, you want to document the vital signs, see what they were. Then while you're 15 minutes into giving the blood, you want to check the vital signs again. Then you want to check the vital signs again within 30 minutes after the first hour, and then every hour after that until the infusion is done. You have 4 hours to give your blood. 4 hours. to give your blood, because within 4 hours, the blood is not going to be any good, because with that temperature, it's prone for bacteria and infections to get inside that blood. So you want to infuse that blood within 4 hours. Me, just so I can be safe, I try to infuse it within 3 hours. Okay, I don't even go for 3 hours and 30 minutes. I just go straight for 3 hours. Or if I can get it in 2:45, then I'll go ahead and do that, 2 hours and 45 minutes. But I try to stay away from even hitting the 4 hour mark, just because I still want my blood to be fresh and not any risk of having infection or bacteria growing within the blood at that temperature, okay? And you may ask, why is it only good for 4 hours when it's been good for all the other times? Remember, it was refrigerated. So when it's refrigerated, you know, the bacteria can't get to it. But once it's out of the fridge and it's outside, you have 4 hours to give that blood, all right? And last but not least, if they do have a reaction, you stop that infusion. You are going to then start another IV. You're not going to push it normal saline into that IV at all. You're going to start another IV. You're going to take out the IV that had the infected blood, because remember, if they have a reaction, even just a little ounce of that blood that you push back into them, right, can cause damage. So you just want to take out that blood, but you want to make sure you get another line first. You have to get another line first, all right? You want to get another line first before you take that out, because if you take that out and they don't have any other IV access and you can't get to them, how are you going to give their emergency medication? So you always want to make sure that you have at least 2 IVs going when you have to give blood, and you want to make sure that the gauge of the needle is a bigger size, around 20, 18 gauge, maybe 16 is probably the best, but if you can get an 18 or 20 gauge, that's even better, all right? And you want to make sure you have 2 IVs. Don't wait for that one to go bad today and start another IV. You want to make sure that you have 2, all right? So in the meantime, you can hook back up the normal saline fluids here while you take out this one, all right? But you never take out one and you don't have another, all right? And last but not least, administer medication to increase vasoconstriction and reduce bleeding. So if you see the patient is bleeding, and you're giving fluids and you're giving the blood and their blood pressure is still plummeting, right? You may want to check and see, hey, if they can get oppressors, all right? And your oppressors are pretty much your vasoconstriction medication. So that's your vasopressin, levophed, epinephrine, neosynephrine, right? All those are going to increase vasoconstriction and eventually help to maintain a blood pressure. If all else fails, right, surgery is going to be performed only if the ulcer is unresponsive to the medication, or if there's a hemorrhage and obstruction or perforation that occurs, okay? So these are your different types of surgeries that the doctor can decide to do. You have a total gastrectomy, a vancotomy, gastric resection, Billroth 1, Billroth 2, pyloroplasty, and then finally your clipping. All right, so I'm going to go now into each one and let you know exactly what's occurring within the surgery. So with a total gastrectomy, you have a removal of the stomach with attachment of the esophagus to the duodenum and duodenum, also called esophageostomy or esophageoduostomy, which of course, you know, that is your small intestines, okay? Then you have your vancotomy, which is a surgical division of the vagus nerve to eliminate the vagal impulse that stimulate hydrochloric acid secretion in the stomach. Next, you have gastric resection, which is a removal of the lower half of the stomach, and usually include a vancotomy, also called enterectomy, okay? Next is the Billroth 1, partial gastrectomy with the remaining segment anamos to the duodenum, also called gastroduodenostomy. You have Billroth 2, which is a partial gastrectomy with the remaining segment anamos to the jejunum, also called gastroduodenostomy. And then last, you have your pyloroplasty, which is an enlargement of the pylorus to prevent or decrease pyloric obstruction, thereby enhancing gastric emptying. I just added this one here. This one is like your non-invasive procedure. It's still invasive, but not as invasive as the rest. And pretty much what they will do as they're doing the EGD or they're scoping the patient, they may go ahead and clip the area. All right, so when they clip the area, sometimes that can stop the bleeding, and as well as mark where they want to do the surgery, because it has a metal clip inside. So when they do go for different testings or so, the doctor can remember exactly where he wants the clipping of where the ulcer is. Then from there, he can go ahead and do any one of these surgeries, or the clipping sometimes itself can resolve the bleeding and it's completely fine. So last but not least, we have post-operative intervention. So after surgery, these are some things that you want to do to monitor, so that way this patient, you know, has a safe recovery and that they're able to continue on and do what they have to do. So again, as you can see, it's not that different from the interventions that you've done before. You're just going to be pretty much doing the same interventions. So you monitor your vital signs, which I told you the main things to watch out for is your heart rate and your blood pressure. All right. You want to place the patient in Fowler's position for comfort and also for drainage. So Fowler, you know, is 30 to 45 degree. Also, you want to administer fluids and electrolytes via IV, because they're not going to be able to eat anything. They are going to be on an NPO status until doctor has required them to be on a diet, but that's only if you hear the bowel sounds. So for 1 to 3 days, until you hear bowel sounds or paralysis, okay, returns, which is pretty much the movement of the GI tract, which is what you're going to hear when you auscultate, all right? You also want to monitor for NG suction, but these patients are going to have an NG tube if they're not intubated, or OG tube, but if they are fine, they will have an NG tube that may be attached to low intermittent suction, or whatever suction that the doctor requires, whether it's regular suction or continuous, or however he wants it. But it will be hooked up to that, so that way all of the gastric contents, those extra fluids or so, extra secretions can come out, okay, to prevent abdominal distension and aspiration. Also, you want to progress their diet slowly, so they're going to go from NPO to having sips of water, maybe a clear liquid diet, full liquid diet, and finally a bland diet, and so on and so forth until they're able to tolerate. So you may see them on a bland diet. They'll try to get small 6 meals in. Some hospitals, they just have 3 times breakfast, lunch, dinner. So you may want to save certain snacks off of the tray, or tell the patient to save certain snacks off of the tray, so that way they can get their 6 meals in. And also, you want to monitor for complications. And what are your complications? Remember, we have our hemorrhage, you have dumping syndrome, and dumping syndrome is pretty much whatever you eat, it goes out of the stomach really fast, and it dumps right into the small intestines. It makes the patient feel very like the abdomen feels very full and distended, and it gives them that uncomfortable feeling, okay? Some can even have nausea or vomiting, depending on how bad or nauseous they feel, okay? You have your diarrhea, you have hypoglycemia, right? Because you're not taking the intake that you would normally take, because you're going to be NPO, and then your vitamin B12 deficiency. So these are things that you want to watch out for your patient after coming off from surgery, all right? So again, I just want to say thank you for watching. If you like this video, please give it a thumbs up. Please subscribe. If you have any comments, please leave it in the comment section below. And again, thank you for coming on this journey of nursing. Have a blessed day.